Good morning, everyone. Welcome to the Bipartisan Policy Center, all of you who have joined us here at the center, as well as all of you that are watching in on the webcast. We've dubbed this week here at BPC the Healthcare Week because this is the third event we've had this week, closing out 2019. On Monday, we had an event that dug into the issue of Medicaid and primary care provisions in Medicaid, comprehensive Medicare. Some of you I see were here for that one. Yesterday we had a major discussion, deep discussion about the patent law and how it impacts upon prescription pricing. And so finally today we're taking another equally challenging issue up, and that is the Stark Law and Anti-Kickback Statute. In October, many of you know, the administration issued some revised regulations on these two statutes that totaled nearly 800 pages. And these were laws that were enacted some decades ago, I think with good intent to prevent fraud and financial kickbacks amongst providers. But they're now viewed in some ways, in many ways, as impediments to where we want to move, it seems to me, in healthcare, and that's a value-based delivery system. So we're honored here this morning to have the President and CEO of Advocate Aurora Health with us. He's going to make a few remarks about this subject directly impacting his health systems, Jim Scottsburg. Jim is President, as I say, and CEO of Advocate Aurora Health. It's the largest healthcare system in Illinois and one of the largest in the Midwest. Jim, as just you should know, has been named as one of the 100 most influential people in healthcare by Modern Healthcare magazine for 8 consecutive years, beginning in 2011. He's a former member and past chair of the American Hospital Association Board of Directors. He's a fellow of the American College of Healthcare Executives and past chair of the Illinois Hospital Association Board of Trustees. And we are particularly happy and honored that Advocate Aurora has agreed to join BPC's Health Executive Council this year, helping us think through a number of these issues that we deal with here. Now, Jim will be followed by Kimberly Brandt. Kim is the Principal Deputy Administrator for Operations at CMS, and that position, as its name would imply, she supports and manages CMS's major programs, of course, Medicare, Medicaid, CHIP, all those. She served, we were discussing this earlier, as a former Senate staffer myself. She was Chief Oversight Counsel on the majority staff of the U.S. Senate Finance Committee with Chairman Hatch, where she served on that committee from January 2011-2017. She is nationally recognized in healthcare compliance and fraud issues, and received this award, received the Healthcare Compliance and Ethics Professional of the Year Award from, boy, this is a long one, Society for Corporate Compliance and Ethics and the Healthcare Compliance Association. Following Jim and Kim's remarks, Marilyn Serapina here is going to have a panel, and we'll dig further into the proposed regulations and issues surrounding this major issue. So without further ado, I'll turn it over to Jim.
Good morning. Bill, thank you very much for the introduction, and pleased to be here with the Bipartisan Policy Center and the team for hosting us here on this very, very important topic of conversation. I'm pleased to represent Advocate Aurora Health and share with you all a bit of our perspective regarding this topic. We have been in the value-based environment for quite some time and have the scars to show for it, and I'm pleased to offer up some introductory comments that maybe will lead into a stimulating panel discussion. So we are, and Bill, thank you again, we are very pleased to be a member of the Executive Council, the Health System Executive Council, and to partner with you on these bipartisan efforts to improve health care for all Americans. We're here today to discuss the accelerating transformation of the U.S. healthcare system to a more values-based and patient-centered system, really through some regulatory reform, which we think is absolutely appropriate. Healthcare is too expensive. And while there are a number of challenges we face in the industry, and yes, we could be better at safety, and yes, we could be better at health outcomes, and yes, we could be better at patient experience, the Achilles heel, I believe, and the one that just plagues the U.S., our nation, is the cost, the high cost of health care. And that's one of those issues that we are absolutely committed to addressing. Our healthcare regulatory system needs to be modernized to ensure meaningful movement from a fee-for-service to a value-based system so that we can better manage patient care and outcomes. I do believe strongly that the current system we have, a fee-for-service system, is part of the problem, and it's no more complicated than the more I do, the more I get. And we see the results of that in this nation, and we think it's time to move from getting paid not based on how much I do, but getting paid on how well I do caring for our patients and our communities. Value-based care is a healthcare delivery model in which providers, including the hospitals and physicians, are paid based on, again, patient health outcomes. Under value-based care agreements, providers are rewarded for helping patients improve their health, reduce the effects and incidence of chronic disease, and live healthier lives in an evidence-based way. We are very pleased that Kim Brandt from CMS is here with us today to discuss the modernization of both the Stark Law and the Anti-Kickback Statute. The administration has taken an excellent first step in modernizing these laws and regulations by proposing the changes that we will discuss today through the panel. HHS and CMS are invaluable partners with us as we move forward in this journey into a more value-focused healthcare system. A distinguished group of panelists, but I will point out that one of them is our very own advocate of Aurora Health's Jeff Barr, Dr. Jeff Barr, physician who leads our whole physician enterprise for the organization and is going to be a great panelist here today. So if I can, modernization of the Stark Law and the Anti-Kickback Statute we think is critical to our Advocate Aurora Health's organization's goal of a more value-based and patient-centered system. In 2018, Advocate Aurora Health saved taxpayers through our ACO more than $60 million. And I think in the last 5 years, we've saved the Medicare program approximately $200 million. So we do have some experience with the value-based model, and it has allowed us to actually bend the cost curve and produce some savings through that MSSP program, all the while providing high-quality care, which is a critical part of that program. An important part of the MSSP is that the program offers waivers from several outdated regulations that we think thwart, if not block or impede, providers' ability to deliver coordinated care and provide patients with the full range of care, services, and tools that they need to stay healthy and to manage chronic conditions. These benefits, however, are only limited to patients that are in the ACOs, and therein lies, we think, part of the problem. Our system is committed to value-based care models. Roughly 50% of all the patients that we care for, Advocate Aurora Health, and mind you, we're one of the top 10 systems in the country in terms of patients that we see. So we have some experience here, and we also operate, if not the largest, the second largest ACO in the nation. But we continue to experience significant and costly barriers to care coordination because of these two laws. For Advocate Aurora Health and many other healthcare systems, more and more resources are being directed at complying with some outdated Stark laws rather than focused on patient care. As an example, and Dr. Barr will go into this in greater detail, our employed physician arrangements require obviously very thorough analysis, which often necessitates regular engagement of consultants, attorneys, third parties to make sure we are doing it right, that we are dotting all of the I's and crossing all of the T's. Engagement of consultants can cost everybody in this room knows how expensive that is, almost $20,000 per contract. We employ thousands of physicians, and so that cost can become astronomical. We are a big believer in having those expenses at the bedside for the benefit of our patients rather than necessarily complying with some outdated rules and regulations that perhaps could be modified. In order to harness the full benefit of the value-based system, compensation arrangements must adjust to reward high-quality, cost-effective care. Advocate Aurora has amended his compensation arrangements to account for value, but the Stark Law does impede us a bit from making more meaningful changes. One example is gain sharing, a term that you've all read about in our industry, that incentivizes savings through innovative care design and services, a program that would pay physicians a portion of realized savings if they can develop and demonstrate truly innovative practices that have good outcomes at a lower cost. This program would save our system, our patients, the government, if you will, money, and it would incent high-quality care and more efficient services. Yet, we find that creating such a program could be construed as a stark violation, and as a result, we adopt a gain-sharing program on a limited basis that doesn't harness the full potential in improving care and reducing costs and improving quality. 21st century care, we believe, requires 21st century rules and regulations. For decades, America's healthcare system has functioned on a fee-for-service model in which caregivers were paid for each test, each visit, each procedure. Instead of paying a fee for every service, public and private healthcare plans are now increasingly turning to alternative payment models and value-based contracts that pay for healthcare based on an overall level of performance for patients. Both the Stark Law and the Anti-Kickback Statute were put in place more than 2 decades ago in a predominantly fee-for-service healthcare system, and as you pointed out, Bill, a few minutes ago, very appropriate at the time, and not entirely appropriate today, just needs to be modified, just needs to be adjusted a bit. As the nation moves to a healthcare system anchored on value, not volume, which is very, very key, and more providers, more and more physicians, more and more hospitals, more and more healthcare systems take on financial risk, then regulations that were meant to prevent overutilization, inappropriate care, are instead unintentionally preventing providers, payers, and other healthcare systems from designing and delivering care systems that meet patients' unique needs, including social determinants of health. So efforts that, if allowed, would help reduce hospitalizations, prevent readmission, advance disease management, and health promotion. We think that all would be supported by some modifications, some adjustments to these rules and regulations. In conclusion, I'm very, very pleased to see that there's an emerging bipartisan policy consensus in our nation's capital to modernize America's healthcare regulatory system to ensure that this transition to a value-based model fully succeeds. And I want to thank all of you again, and the Indian administration, Kim, for being here today, and for your partnership on these very important regulatory modernization initiatives to pave the way for accelerating transformation from fee-for-service to fee-for-value. We believe that's what's best for the United States of America. Thank you for the opportunity to share some comments. Kim, I'll turn it over to you.
Thanks so much for having me here today. I'm thrilled to be able to represent the administration and talk about some of these important changes that we have made collectively across HHS to these important rules. So let me kind of take a step back and give you a little bit of context and history about why we started making these changes and how we got here. So at CMS, this all started when the administrator came in March of 2017. She started an initiative called the Patients Over Paperwork Initiative. And what that was intended to do was to be able to find ways to reduce burden on providers, find things that providers saw that were standing in the way of their being able to provide good patient care, and figure out ways that through our CMS rulemaking, because we make just a few rules at CMS, that we could address some of those issues and really be able to improve upon them. So in 2017, every single one of our payment rules included a request for information in which we asked for feedback. What are the areas that you as the provider community are finding they're standing in the way of your being able to do your jobs well? Not surprisingly, we got a lot of feedback. We got several thousand comments, and we went through and actually categorized and read all of them. And in fact, I'm happy to report as of today, we've addressed about 80% of the ones that we had control over, which has totaled in a savings of about $8 billion and about 40 million hours of reduced burden on providers. But not surprisingly, the top 2 categories were first documentation, because most providers felt our documentation requirements were too much, too vague, just too much in general, and so we were trying to address that. But then somewhat surprisingly, the second biggest bucket of comments we got was compliance with, implementation of, and interpretation of the physician self-referral or Stark law. And it was something that I think that while I knew about that, because it's an issue that I have been following for years, or it follows me, I'm not quite sure which, it was something that was definitely a surprise to many people at CMS. And so the timing was right, because when I came on board in the fall of 2017, the administrator was kind of going through this and saying, wow, we really should do an update to the physician self-referral law, and said, Kim, you know how to spell Stark, why don't you take that? And we'll go and start looking at what we can do. So the technical team and I really started looking through all the comments that we gotten, which were over 1,000 comments just on those RFIs, dealing with ways that people felt that there were burdens and impediments to implementing the physician self-referral law. Along that line, though, the department as a whole, under the leadership of Deputy Secretary Hargan, decided to go ahead and launch a regulatory sprint to coordinated care. Notice it is not the regulatory marathon, it's the regulatory sprint to coordinated care. And so that started in the spring of 2018. And the goal of that was to really look at 4 areas across the department that really were things that the department had been hearing about that were standing in the way of the move to value, and a lot of the things that was just mentioned in the opening remarks. The 4 areas were, first of all, the physician self-referral law, which falls under CMS. The second was the Anti-Kickback Statute and the accompanying safe harbors, which is under the purview of the HHS OIG, and I know that'll be talked about on the panel today. The third was 42 CFR Part 2, which is under the purview of SAMHSA, the Mental Health Administration, and that was involving the sharing of protected patient information, but is particularly a big deal right now because of opioids and a lot of the opioid care coordination issues that are out there. And then the last was under the Office of Civil Rights, updating the HIPAA regulations, which have not had an update in quite a while. So collectively, we all started off on our sprint, but for better or for worse, CMS was already a little bit ahead of the curve. And so in June of 2018, we issued a very specific request for information, whereas the other requests for information were more global. What are the burdens you're seeing? What are the impediments you're finding? Our RFI was extremely detailed. We actually took those 1,000+ comments that we got from the earlier RFIs and asked for specific examples of where the Stark and physician self-referral law were standing in the way of care coordination. What was it about the law and the accompanying regulations that were particularly problematic for providers? How did they see us being able to update it? What did they think needed to be changed so that we could make it so that we would not be in the waiver business anymore, as was mentioned? Under our current authority, we have the authority to give waivers for certain types of models under the Medicare Shared Savings Program and for certain other types of arrangements under models that are under our Centers for Medicare and Medicaid Innovation. But that's it. Those are, just very specific to those models and do not have a global ramification. So in response to that RFI, we got back over 375 comments, totaling about 3,500 pages. Extremely detailed, extremely thoughtful comments. I did a similar exercise when I was at the Senate Finance Committee, where we asked for comments on updating the Stark law as a whole, not just the regulations. And the comments there were much more general, such as, this law sucks, we hate this law, get rid of the whole blankety blank thing. The comments we got in response to ours were much more detailed. Some were as high as 50 pages, giving us extremely complicated and detailed examples of types of care coordination arrangements and how it was that we really could make changes to the law to really be able to address that. It was extremely helpful to us, and despite the fact that I think that's why I needed new glasses this year, it really was having all of that very specific feedback that allowed us to really be able to craft the beginnings of what you see in the proposed regulations that went out in October. Simultaneous to that, though, just as our comment period closed in October of last year, in August of last year, the OIG issued a similar RFI for the safe harbors and the anti-kickback law. They went ahead and did a 60-day comment period as well. They got back about 350 comments, so slightly less than ours. I guess we win, if you will. But also totaling, several thousands of pages. And then together, in the fall of 2018, the OIG and CMS did something that is somewhat unique for us. We worked very closely together. As you know, the OIG is our oversight arm, and so while we love and appreciate them, we don't always work super closely with them. But in this case, we thought it was really important for us to go together through all the comments and really look at the areas, because there is a lot of overlap between the application of the two laws, to really figure out how it is that we could look at things like common definitions of what is a value-based enterprise, what is a target population, what is a value-based activity, what are the things that really are encompassing this whole new bold world of value-based care, and how is it that we could have common definitions between us to really be able to have it. Understandably, our laws are very different. The physician self-referral law is a civil statute, and it's a payment rule. So it's strict liability, which means that it's pretty easy to be able to go ahead and get someone under it, because you don't really have to show intent or anything. The anti-kickback is a criminal statute. It's intent-based. You really have to show that someone intended to violate the law. So what we really wanted to be careful of was to be true to the intents of both of those underlying statutes, but still make sure that we had commonality in the definitions as much as possible. So what you'll see, hopefully, for those of you that have read through all 800 plus pages of the combined rules, is that we really did try, whenever possible, to have common definitions and really try to approach it as a department as a whole, as a coordinated as way as possible. So with that being said, I'm going to now turn and talk to you about some of the specific things that we did with respect to the physician self-referral law. Our whole goal with this redo of the regulations was to modernize and clarify the regulations. It was not to get away from the intent. The intent of the law is good. You need to be able to steer against or to stop inappropriate referrals or inappropriate steerage that would be in the harm of the patient. You don't ever want a patient to be in a situation where they are going to be potentially put in a bad situation because you've got a provider who is going to give them an inappropriate referral. However, we also recognize that the original Stark law in particular was passed back in 1989 and has not had a significant update regulatorily since then that was geared towards value-based. It's had other updates in other ways, but in terms of the new shift to value-based, there really hadn't been an update, and we wanted to be able to do it in such a way that hopefully would stand the test of time. So what the proposed rule includes are, first of all, a permanent exception to the Stark law for value-based arrangements. We have 4 of them. The first is where a value-based enterprise has, during the entire term of the agreement, assumed full financial risk. So you've assumed full risk, you get a full exception, because our thought is if you've assumed the full financial risk, that in itself is a check and a balance. Secondly, where a value-based arrangement under which the physician is at meaningful downside financial risk for failure to achieve the value-based purposes of the value-based enterprise. So again, you have to have those tests of value-based, but there also has to be some financial risk with it. Third, any value-based arrangement, provided that the arrangement satisfied specified requirements. And lastly, other circumstances under which the first 3 that I just mentioned would apply to an indirect compensation arrangement. So we have proposed those as the proposed exceptions, which we think would take us out of the waiver business. They're broad enough that it would allow for most of the types of things that we think need to occur to be able to occur without us needing to give an individual waiver. But that's part of the reason we put them as proposed, is so we could get input from all of you as to whether or not we hit the sweet spot on all that. The other things that we included in it, just to quickly finish up, are updates to the definitions. We had never, through statute or through regulation, defined key terms such as fair market value, general market value, commercial reasonableness, volume and value, some of the key things that are really the tenets of the rule itself. And we had never attempted to really clarify what those were. In particular, with the general market and fair market value, we spent a lot of time with valuators, the people who actually do that, and talked to them about how they did it and how they came to those conclusions, and used a lot of that feedback to update our definitions. We also put some protections in there for non-abusive beneficial arrangements, such as being able to pay for cybersecurity so that a physician practice could actually be able to transmit electronic health records to their accompanying hospital or health system without fear of having a Stark violation, just because they've got that cybersecurity protection to ensure that nobody's PHI is compromised. The same thing with patient data matching types of things, being able to share patient data between a primary care and a specialty care physician, such as if you have diabetes and want to share things from a glucose monitor, that type of thing. And then lastly, we asked for comment on the rule of price transparency at the point of referral, to wonder whether or not we should require, if you get one of these exceptions, people to be required to make sure and tell the potential patient of the downstream costs of that referral. So in conclusion, what we've really tried to do across both of these rules, but in particular with the physician self-referral rule, is to really take them and update them to hopefully stand the test of time so that we won't have to do another set of these updates, another 5 years, hopefully even another 10 years, so that we have the flexibilities that will allow it so there can be better care coordination and patient protections, and to allow it so that we can be able to sort of move forward and really get people to be able to do these types of value-based arrangements and enable them to really focus on that quality and not the volume, but really the value of the care that's being given. The deadline for comments is December 31st, so save your holidays, get your comments in a little early. People were asking me earlier how many comments we have in thus far. We have about 100 legitimate comments. There was a glitch where we got linked to the price transparency rule, so we had over 1,000 at one point, and we were all excited until we realized they were all form rules or form comments, but we have about 100 real comments. My favorite one thus far says, "This rule rocks," so we're pretty excited. If you want to send that in, we'll take all the comments on that you'll give us. But I really do encourage all of you to send in your comments and to be very thoughtful and very specific. What the comments we got in respect to the original RFI really did help us to drive and I think create a rule that at least thus far we've heard pretty positive feedback to. But let us know where we didn't get it right. Let us know where we need to tweak some more, because that's the whole point of the regulatory process. And our hope is to finalize both our rule and the accompanying anti-kickback rule sometime in 2020. So that gives us a broad range. Anyway, but the goal is to get both of them out next year, and hopefully we'll be back to talk to you about what the final are. Thank you very much.
Thank you, Kim. Rocks versus sucks always wins out. First, I would just say, Jim, he's left, I think, this idea that the 21st century care requires that we have 21st century payment models does seem to me make it very clear that changes are required here. I'm going to ask the panelists to come to the stage, and I'll quickly just welcome all of you. And Marilyn Serapini, our director of our BPC Health Project, is going to moderate this panel, and I'll let her do the introduction of these people. Thank you very much for taking the time to come out this morning and participate in this discussion. Marilyn?
Great, thank you, Bill. And good morning, everyone. Thank you for being here. I'm not going to do a whole lot of commenting myself because we've already had introductions of the issue and we've already heard a lot about it, and I'd like to get right to our panel. So with me today, sitting next to me is Jeff Barr. He's Chief Medical Group Officer at Advocate Aurora. And then next to him is Debbie Curtis. She is the former Chief of Staff for former Congressman Pete Stark of California. You might notice that name Stark. That's what we're talking about today. So Debbie is going to be able to help us to understand where we're coming from there. Next to Debbie is Taylor Jones. She's Senior Counsel at Aiken Gump and focuses quite a bit on value-based care and ACOs. And then next to her is James Mandolfo. He's Senior Policy Advisor at the Domestic Policy Council at the White House. James has spent quite a bit of time working on the anti-kickback statute as an attorney. And then next to him is Paul Westphal. He's the Washington Counsel for the American Medical Association. So I wanted to start with Debbie. Let's just go back to the beginning. Let's talk about why we have the Stark Law in the first place. What were we trying to do? How has it behaved? So take us back to the beginning and tell us what we were trying to do.
Sure. I hope people know the Stark laws were not dreamt up by Pete Stark as something to torture the medical system with. It was not. It was also not to develop a new practice of law. I would also, definitely he would say that. I mean, there were very significant problems with self-referral and very well documented evidence that where there is an ability to gain, referrals happen. And those referrals happen to the benefit of the practitioner more so than to the benefit of the patient. And in fact, patients have died because of self-referral, where they get extremely low quality care, unnecessary services, and things go undiagnosed because of the way that the referrals work and what has happened. again, these were very well documented before the Stark laws came into place, and they're still happening. What Pete would say if he were here is that, and I know I read this all the time where people say, even Pete Stark hates the Stark laws. We need to change them. And it's true, Pete Stark is not a fan of what the Stark laws have become because he thinks they've become a roadmap for how to circumvent them. And if he could wave a magic wand, he would go back to thou shalt not self-refer. And if you do, you're liable. And let everybody be in that jeopardy to be able to prove what they're doing is a value to the health system and not something they're doing in order to profit. I'll give just a few examples of things where we've seen this continue to happen in our health system. I mean, where physicians own physical therapies, they employ physical therapists. Lo and behold, GAO studies that a whole lot more physical therapy happens for people if they're being referred to employee physical therapists. You know, we had the whole situation in the early 2000s where physicians began owning hospitals. These hospitals were not staffed 24/7. They were performing major surgeries, and people died because, in one example in Texas, many of these examples do come from Texas, unfortunately. In Texas, a patient had a severe reaction post-surgery. The equipment was there to save the patient's life. It was under lock and key. The nurses were not allowed to have the lock, the key in order to open the lock, and the patient died. So there are countless examples of where referral has caused real patient harm. And I would remind everybody that both the HHS-IG and the Department of Justice over the years have said that the self-referral laws have done more to reduce waste, fraud, and abuse than any other single law that has been enacted. They are really important. That's not to say they don't deserve looking at. Every law deserves looking at. And you do need to take the pace and see, has this kept pace with time? But I guess I just take a little umbrage at the notion that when the Stark laws were passed, it was a totally fee-for-service world and everyone agreed this should happen. That was not the case. They were hugely opposed when they were put in place. And, it is not today that you have this sudden difference where people don't want to profit. People still want to profit in healthcare. Companies still want to profit. It's still there. And so my argument is just everything here has to be done carefully. And in my review of these proposed regs, and CMS is really lucky to have Kim there. She's been doing this work forever. I have huge respect for her. But there are a lot of unintended consequences when you make changes. And I see some of these changes as being ones that open broad new avenues for waste, fraud, abuse, and potential patient care, and it makes me very nervous.
Can you be more specific about what is making you nervous?
Sure.
That's in there?
Yeah, a value-based arrangement. It seems to be what someone names it. And so I just have a very hard time really concretely understanding what you have to do to qualify as a value-based arrangement. And it looks to me like you can use nice words to skirt the law. And to me, we have a waiver process. CMS could do work internally to figure out what kind of value-based arrangements should get waivers, create some templates, and do things in that way for a few years and see how that's working. I mean, ACOs have that process and they're working. You see a lot of value-based practice happening around the country, and it's happening with the Stark laws intact. And so I don't necessarily see right now being the time to do this without more specificity about exactly what is being done.
I invite other panelists to jump in here.
My name is James Mandala. I'm with the Domestic Policy Council at the White House, and my background, just to clarify, was a little bit in fraud and investigations. And I would say that in response to that, one of the key focuses of the anti-kickback statute and the safe harbors are the actual safeguards that are being put in place to ensure that we try and prevent fraud and abuse. And when you look at the safeguards that are set forth in the safe harbors, for instance, in the care coordination arrangement, you have requirements that the arrangement and the objectives be in writing. So, for instance, if a group of providers are going to try and defraud the system, then there is going to already be a framework for what they should have been doing, and then they can be challenged at a later time for how they were actually working. So I would combat that and say, yes, there are going to always be people who are going to try and providers who are going to try and game the system. But this particular safe harbors and the proposed rules have provided the ability for the anti-kickback statute to continue to have the integrity that it deserves and what it has always had, and to prevent the corrupt inducement of referrals will continue to happen because of those safeguards that are in these proposed rules. And if there are additional safeguards that others believe will make this particular rule even that more strong, then of course HHS and the administration would love to review those comments.
What are some of those safeguards? I'd like to hear from the panel, because here we're talking about there is a lot of support out there for changing the law and the statute so that we can, respond to some of the providers who are saying they've got some barriers. So how do we create that kind of a balance so that providers can move forward, but yet we continue to have the safeguards in the law and the statute that will deter fraud and protect consumers?
I think we're talking about making the clinically right thing to do, the clinically excellent thing to do for all patients in all venues of care, the easy thing to do. And I think we've unwittingly made doing the right thing a little harder, a little more confusing. So even if the statutes allow for certain things, ambiguity and confusion on the part of provider organizations, individual practices, that fear of penalty rather than seeking reward for innovation and excellence, and not self-induced or the inducement of self-referral and so forth, that fear of penalty has prevented innovation that I think 21st century care demands. So I think clarity around definitions that we heard Kim Brandt talk about is going to help a lot. Reducing some of the time spent on administrative tasks around simply compensating our clinicians and clinical care teams for the work that they do. As you pointed out, there are many ACOs that work and work very well. As Jim Skogsberg mentioned, Advocate Aurora has done very well in that environment. Others have as well. Think what we could do if that ceiling was raised or obliterated altogether for the well-intended or the well-performing. So I think that making the right thing the easy thing to do from a statutory standpoint is key.
But let me ask a question.
Sure.
You said for the well-intended.
Yeah.
How only the well-intended are going to use this?
Well, no. I do.
I mean, that's my concern, is that if you want to do it, there's a path to do it now.
But do the statutes in fact cast too wide a net and unintentionally capture not the those who are kind of flaunting the law or knowingly violating it, and have we unwittingly captured those that would seek to innovate, to advance safety, to advance health outcomes, to advance not only patient but clinician experience? I think we have.
So give me an example. What have you not been able to do? That's my question.
So we're facing a tidal wave of chronic disease in the United States. So whether we know it or not, we always tend to cite the singularly expensive order, the MRI, but really chronic disease over the lifetime of a person or people. If you look at the amount of chronic disease in the population over the age of 50, over the age of 65, and the cumulative cost, to really move the needle on those diseases, we're going to have to address wholeheartedly social determinants of health. As a primary care physician, and I still maintain a practice, there are certain remote monitoring devices that I cannot provide for my patients, that my system cannot provide for my patients, that would actually allow me more eyes and ears on that patient to help them clinically and not compel them to come into my clinic every 3 months and I'm on this productivity treadmill. I can't really do that for fear or in actuality triggering Stark, triggering anti-kickback. My system.
Have you tried a waiver?
Well, but I shouldn't have to, because again, trying for a waiver, the waiver's great. I appreciate it, and I appreciate the safe harbors and the waivers. That's great. But again, that's another hurdle that I have to go over as a clinician to do the right thing, and that's really what I'm talking about. So.
Taylor?
I just want to note that the possibilities for obtaining exemption in these scenarios are very limited. I mean, there is the waiver process, as you've noted, but that is only for CMS-sponsored models and CMMI models. For other, more models that are not necessarily those sponsored by CMS, those maybe within this health system, those are not eligible for the waivers. And the other option is the advisory opinion, as you're well aware, and those are very difficult to get, take months and months, and only apply to the person that's requested them. You can't basically copy that program and then show that to CMS or OIG if they come knocking. I mean, obviously, it provides some guidance as to what CMS and OIG are thinking, but those are not workable solutions. These types of arrangements are becoming more and more popular due to rising costs, as we've noted. The whole nature of these value-based arrangements is that the incentives have changed from what they were in fee-for-service. So there is no longer, arguably, the incentive to overprescribe or over-refer. You receive payment within these arrangements for high-quality, low-cost care. And so there are, in my opinion, I think there are very well-drafted safeguards in the exceptions and the new safe harbors for these arrangements. But I think we should also remember these arrangements themselves contain safeguards inherent to the type of arrangements.
Is that because you are assuming risk? Is
Yes,
that really what it is?
because you're assuming risk.
But I don't think all of them require the assumption of risk.
They don't all require the assumption of risk, and that's a good point. For example, the Stark value-based exception does not require a risk, but it does require that the value-based arrangement comply with the definitions, which, in my opinion, are drafted well enough to prevent this type of overutilization or increased cost to federal healthcare programs that you would see in a fee-for-service model.
Mm-hmm. Paul, where is the AMA on this?
I mean, we are obviously, we're not out there, it's always the balance, because we want to have honest providers flourish in the healthcare system, and we want the bad actors to be punished. And so that's always that balance between those two things of innovation and looking at that from that regard. So when we look at from an administrative burden perspective as well. So, we're obviously in support generally of the concepts of these value-based exceptions and of the safe harbors, but we're also looking, again, from an administrative burden perspective. So that no risk or care coordination anti-kickback safe harbor has 11 requirements and 7 definitions that a physician practice has to meet. And so that's concerning to us from an administrative burden perspective, that you have to meet all these requirements, including they're introducing outcomes and outcome measures both into the anti-kickback safe harbor with that, and also they're updating the personal services and management contract safe harbor for outcomes-based payment. So you have OIG, which is a criminal law, entering into the world of outcome measures. And there are a lot of concerns we have with outcome measures, generally speaking. The fact there's not enough of them, you have to be at a group level at this point. You can't get down to individual physician. There's not enough sufficient infrastructure from an interoperability perspective in order to have these types of measures. And then also just patient tracking as well. So it's also just, it's an outcome. Like a physician can provide the best care and do all the things that they can do, but if the patient doesn't take their medicine or they don't show up for that meeting that you try to get them to show up for, you could potentially have a poor outcome. And the other thing that we're looking and we'll be making comments on is the time period in measuring those outcomes. They're looking at about a year-long basis, but really it's 5 to 10 years is what you should be looking at for quality and for outcome measure basis. So we're looking at those sorts of things. So outcomes is a concern. There's the 15% contribution requirement for any in-kind remuneration, and it's only limited to in-kind remuneration as well. So any shared savings or anything like that, you're going to have to fit that within a different anti-kickback safe harbor. So again, more compliance costs, potentially that outcome-based personal services safe harbor as well.
So how much of this is about what is in the law and the statute, and how much of this is clarification that providers are unsure of what they're doing and they're nervous about, wading into dangerous territory?
I think it's a significant component. I think Kim Brandt touched on greater clarity of fair market value, commercial reasonableness. I think that's important. But like I said, we're getting the results that the system is designed to produce. And if it's a strict liability environment where punitive elements are pronounced, we will get the results that that's designed to produce, and that is a lack of innovation. People will be less apt, systems will be less apt to kind of wade into the circles of innovation to design patient care models that our patients need and deserve in a rewards-based environment, or that is just simply better understood, perhaps less punitive, especially where intent was not nefarious. I think you're going to get better innovation, better care, better outcomes, more engaged clinicians. And I think whatever we can do to simplify the administrative burden along the way, again, not to sound like a broken record, but I think we will in fact make the right thing to do the easier thing to do.
You know, as an outside counsel, I advise clients all the time on arrangements that they worry may implicate the Stark Law and the Anti-Kickback Statute. And I can say, you know, very confidently, they are very risk averse. And if there is any question whether these laws would apply to these types of value-based arrangements, most of my clients are not going to want to enter into those arrangements. You know, CMS and OIG, they have a very big stick. You know, as we noted, Stark Law is a strict liability law. The Anti-Kickback Statute can result in a violation of the False Claims Act, which can result in treble damages, and both violations can result in exclusion from federal healthcare programs. And so, you know, to the extent that an arrangement might possibly violate these laws, my clients aren't going to want to enter into them. And, you know, some of these arrangements very clearly violate the laws as they're currently drafted. And so, you know, again, to the extent that we want to promote this transition to a value-based care from fee-for-service, you know, the laws have to follow us as well.
I guess what I would say is I really have a difficult time understanding exactly what's needed to be changed in the Stark laws to pursue value-based care. I hear that it's a hassle, and I get that. And there are things administratively that could be done to ease that. Sure. You don't have to change regulations. You certainly don't have to change the law to make a process work more effectively. So that's a very real issue, and I acknowledge it. I think there's multiple ways to do it. I just really worry that every time we've added specificity to the Stark Law, it creates ways for people to move around it. And you create unexpected outcomes that cause real patient harm and fraud, abuse, and waste.
But there have been unexpected outcomes in the way that the statutes are written currently as well. And I
don't disagree. I do not disagree.
We're in alignment.
Yeah.
And as a profession, we don't want the bad actors out there. It erodes the
Yep.
credibility of the profession. It erodes patient care avenues. So I'm right there with you on that. But I would say we can't paint with too broad a brush. There are some physician-owned and operated, clinician-owned and operated entities that have been some of the safest, highest quality, most effective and efficient institutions in the country as well. And so I don't want to let one or two or more bad apples spoil the whole bunch. So, but I agree. There needs to be punitive measures in the law. So I don't want to sound like an apologist for those that would skirt the law. But that said, I do think that specifically defining a value-based entity or what value-based care is or what a target population is, I don't see a lot of harm. We're not going to get it perfect. None of this is etched in stone to my knowledge. So what's the harm in trying, I guess I would ask?
I guess I would say the harm, maybe you do number one where it's entirely risk-based. But as you walk down that continuum, I start to lose clarity and I start to be very nervous about what happens. And so, I mean, I would even say if there were exceptions, if you had 10 exceptions that have been approved through the law and you fit in, there's a, you know, you're really basing this on evidence of what we've seen that works and be very clear about it. I would feel less uncomfortable than just it says value-based arrangement.
And I understand that. For me, the issue is one of sustainability. We are not in a sustainable system right now. If we don't institute value-based systems to manage a deluge of chronic disease that is lurking, and it is lurking, it is going to submerge every high-performing system right now. we won't be able to handle the amount of chronic disease out there unless we are given the leeway to create more innovative systems to deal with chronic disease across venues of care more effectively and more efficiently. I currently reside in Wisconsin, but my system exists in 2 states, Illinois and Wisconsin. Wisconsin's projecting a primary care clinician shortage, not just physician. And so we have to be able to do more with less. And in the current environment, the way the statutes exist, whether in effect or not, they limit what we are willing to do, the extent to which we can go out on that limb and provide and create innovative care models. So it comes down to sustainability, I think.
So, James, I wanted to get to you. I wanted to ask you, in the comments that you're collecting, what specifically are you looking for? What areas would be most helpful for commenters to address? So what are the priorities here?
I don't want to prioritize any particular comments, but I will say that getting to the safeguards, there's not only specific safeguards that must be met in order to achieve the safe harbor, but there's also industry that has expressly been excluded from some of the safe harbors. So for instance, if you look into the actual proposed rule, there's pharmaceutical manufacturers, DMEs, laboratories, and what will be interesting is to find out if there is another way of proposing safe harbors for industries that may not necessarily currently be under the proposed rule, but are there ways to include those aspects of the healthcare industry with extra safeguards or additional ways that we can ensure that there are more of the industry at the table. And I think that will be something from the comments that will be interesting to read. I also think it will be interesting to see how the comments relate to the safeguards. Are there additional safeguards that will make those who are skeptical of the new rule of the proposed rule that will tighten it up, that will make it so that we can prevent future fraud and abuse? Because we do want to get this right. I mean, we want to modernize the rule, but we also want to achieve reduced abuse and fraud to ensure that patients are getting the best treatment at the cheapest cost. And to do that, it will require the proper safeguards that are attached to the safe harbors in place. And so those comments, I think, what we're discussing here is really an aspect of this rule that is important.
And then one thing that I'll be interested in looking at other comments and something that we're commenting on too is what's the impact on small practices, rural practices, and underserved areas as well. Because that's something that's of grave concern to us at the AMA, that these are going, like you are going to have to be a part of a value-based enterprise that's a part of a hospital that's going to lead to further consolidation of the marketplace due to these rules. And there are a lot of proposals in these rules, if anyone's actually read through them, that you have the kickback, value-based safe harbor, and they're like, we're doing all these things, and then we're considering like these 8 other things as well. And don't just be like, oh, they're considering, they're not actually going to look at it. They are looking at it. The OIG and others read the word considering to mean proposing. So it could actually show up in the final rule and be a finalized project. Well, because what they're doing there is they're setting the basis for any legal challenge from a logical outgrowth test thing from administrative law perspective is what they're doing that. So you could see any of those things actually come into the final rule and be a requirement of what you have to meet. So don't dismiss the little considering here, considering X and Y and Z and Q and all that. You should really be looking at those things, and they'd be looking for comments on all that.
So let's pick up on something you just said. You mentioned consolidation of the market, and as we know, there are many markets that are highly concentrated, and you also mentioned rural areas where there's a lot of consolidation as well and coordination as well. So how has consolidation of the industry, what is the impact there, and does that make it even harder to work together, to coordinate, to avoid, frankly, self-referral?
I would argue that consolidation has tremendous upside if done properly. Obviously, there are some potential pitfalls, but where we see it done well, we see greater opportunity to coordinate care across venues of care. So where I see a transition in care, I see potential error from ambulatory setting to ambulatory surgical center to acute care center. So where you have different entities owning, operating, providing care in those venues, where patients traverse teams, traverse venues, you see error. And so consolidation allows for the standardization of care practices, standardization of utilization of healthcare products and resources, and actually better and more effective and efficient deployment of human resources, clinical professionals. So I can now have a neurosurgeon who can interact across a footprint, either in real time, in person, or virtually within a consolidated system where that may not have been able to exist previously.
I guess I might want to weigh in and just say, as I sit here and listen to this, I feel like we're putting an awful lot of hope in some changes in the Stark laws and the Anti-Kickback statute to change the U.S. healthcare system. And I might take a step back and say one of the biggest problems we have in our healthcare system is that people don't have medical homes. They don't stay in the same place very long. We move, we get different employers, that changes our healthcare. I mean, there are so many external factors that impact the ability to pursue value-based care. And I feel like this is a little too narrow of a framework to look at this. Let's get rid of the Stark laws, and you're going to still have huge problems doing what you want to do. So I guess, you have to look and then if you talk about global warming, maybe none of this matters. But, we can get bleak. But I guess, to me, we have laws in place because there was real fraud and abuse and danger happening. There's innovative ideas that people want to pursue, but I don't see benchmarks laid out in each of these definitions. What do you have to do in order to qualify? And when I see something that vague, that's where I see the ability to have huge unintended consequences.
Yeah, without it took us decades to get here.
Yeah.
No doubt.
Yeah.
And we're not going to get to the ideal place in 2 or 3 years unless we deal with the pebbles in our sandals. And this is a major pebble in our sandal. And so I'm not going to avoid this just because it's not going to solve the whole enchilada. Let's take care of each problem as we can, and I think this is a clear and present opportunity. So
I'd like to hear from you and from Paul and from Taylor about what is it, where do you see, if these laws are changed via these rules, where do you see the provider community going? How far will we go? And try to be specific in what directions. What more are we going to see?
I'm happy to start. So I think just to sort of come back to a point that you made, Debbie, a minute ago, about using these changes in the rules to change the marketplace, I think it's switched. I think the marketplace has changed and the rules need to follow. The way they're currently structured, they're actually a barrier to that change that most folks would argue is good. And I think, as if we look to the private sector, to the non-federal healthcare program sector, they're a lot more innovative because they're able to be. And so I'm hopeful that allowing federal healthcare program beneficiaries and the federal healthcare programs themselves to benefit from these value-based arrangements, is going to really revolutionize the marketplace overall.
I think you'll see, hopefully in the optimist in me, more coordinated care between different types of providers so they don't have to have concerns about the self-referral law and anti-kickback. I think you could see physicians who are providing better value care get rewarded for providing that better value care through shared savings because they can't do that outside of the Medicare Shared Savings Program right now because it has a fraud and abuse waiver. So I think you'll see more of that and hope it's all beneficial. And then to get to, well, as previously mentioned about like remote patient monitoring and digital health tools and that sort of stuff, you have the patient engagement and support safe harbor, which currently is a requirement that you have to be a value-based enterprise to be a part of that. But that gets to a lot to they explicitly, OIG calls out social determinants of health. It's a huge issue for the AMA, it's a huge health issue for everyone that we're looking at and are very in support of that concept of supporting those things so that, because healthcare and health data and health everything is now, it's now everything is a part of that definition. So it's, being able to supply an air conditioner to someone who has asthma that can't afford it, to help their care, to helping someone sign up for social services, to get food stamps and those sorts of things. So, and then also the digital health tools and the smart pill boxes and that as well, to have physicians and clinicians more greatly provide that to their patients so they can better manage their care and so that they aren't also being inundated by a whole ton of data, that they can start making eye contact with their patients again and stop making eye contact with the computer screen.
I'd piggyback on that, and especially on the social determinants of health elements, truly getting to where we can meaningfully move disease treatment further. If you look at hypertension as an exemplar, we've kind of plateaued in terms of our treatment of hypertension. I can prescribe medication and tell you to advise you to work on lifestyle changes, but that does nothing for your ability to actually come to my office for the visit. It does nothing for nutritional counseling that I can't offer right now, remote monitoring of blood pressure right now. If I see a well-controlled blood pressure patient every 6 months, I'm basing an entire treatment plan on 2 points of data over the course of a year. I could get 365 points of data across a year if more enabled along the lines of value-based care planning.
So before, we're about to open up for your questions, but first I'd like to give each of you an opportunity if you want to give your one takeaway. What is your biggest priority for either moving forward and what you would like to see happen or what you would like to see not happen? So we want to start on the end with Paul, if you have anything to...
I think I'll reiterate the impact on small, rural, and underserved practices is something that we're going to be focused on, and also whether or not these rules are going to be adding more administrative burden onto the practice of medicine, and that is this a broad brush requirement, and how do we make that balance between innovation and making sure that the bad actors get punished. And then I'll make a slight small plug for the cybersecurity safe harbor and the cybersecurity Stark exception. Those are very good. We're very much in support of it. And because we're going to be, as part of value-based care, we're going to be exchanging a lot of data. We want to make sure that data is secure. And so to have the ability to donate software and services from a donor to a recipient in the way that has been laid out, we're very beneficial of it. Right now they aren't allowing for hardware to be shared. Understand the concerns that are associated with that, but they do also offer an alternative that if you allow the donor to do a security risk assessment of the recipient's need for that hardware and the donor's own security risk assessment of itself, that then that hardware could be donated. And that's very beneficial from us because that is like one of the few positive incentives that we've seen from the administration as far as if you get a security risk assessment, you get something positive in return rather than another reporting requirement or another burden, that sort of thing. So we're very much in support of that alternative.
I think just as the proposed rules have put out in the policies, as the healthcare industry goes into value-based care and coordinated care, it's important that the rules that once served an extremely important purpose and still do become modernized with the current structure of the healthcare industry. And to do that, we needed to modernize Stark Law and the Anti-Kickback Statute. And the particular safe harbors that are in place provide the requisite safeguards that will ensure that fraud and abuse is limited while at the same time preserving the integrity of the Anti-Kickback Statute and the purposes that it was meant to serve, which will in turn reduce the cost for patients and also provide better care. And so we're eager to review the comments and review everything that's been submitted and to eventually have final rules.
Similarly, I want to express support for the specific value-based exceptions and safe harbors in both rules. I think they're both necessary, and I am hopeful that they'll be adopted and finalized. And I also want to touch on something that we haven't had a lot of time to discuss, although Kim mentioned it in her talk, is I really want to also support and appreciate or express appreciation for the consistency or the coordination between CMS and the OIG regarding the two sets of exceptions and safe harbors, and having similar but different exceptions and safe harbors is an incredible burden on those in the industry that are governed by these laws. And to the extent that the agencies can make those exceptions and safe harbors consistent and aligned with each other and utilize similar definitions, those of us in the industry would like to express sincere appreciation for that.
And I guess I would say, if I were channeling Pete Stark, when everyone's applauding, that's not when you drop the gavel. And there's a lot of applause for these regs coming from industry. And I think that's coming because they're very broadly written. And I came today hoping I would hear more specificity of what particular arrangements can't happen today and are impeding value-based care. And I'll be honest, I'm not leaving with a clear understanding of what can't be done under the Stark laws today. And so I would leave saying, I think the number one priority is first, do no harm. And I don't think that bar has been met with these as they are written today. And I hope that there can be more specificity added and real thought given to the unintended consequences of modifying in this nature.
So Jeff, I think that sounded like a challenge. You have one more opportunity to convince Debbie.
I don't disagree with the need for clarity, and I guess that's what we need to be able to explore this space. I think right now the desire to innovate has been deadened somewhat. I won't call it learned helplessness across the industry, but I think the specter of triggering Stark or anti-kickback has deadened some of the creative juices. But I think this gives us hope. I do think that the ability to connect with patients, even when they're not in the four walls of my exam room, OR or ED, will be extremely helpful. The ability to partner more meaningfully with federally qualified health centers in a way that allows FQHCs to do what they're intended to do, and for us to assist them in that without the fear of triggering any liability would be wonderful. And the ability for primary care and specialty care to share data analytics to the betterment of our patients' health without necessarily generating more cost would all be wonderful.
Okay, let's open it up to audience questions. And I know from talking before this event that we have Congressman Phil Gingrey in the audience, and he has a question for us.
Well, thank you very much. Look, it was a great, thank you. Can you hear me? A great discussion, great panel, and open remarks from Jim and Kim. Yes, I'm a retired OBGYN physician with 27 years of clinical practice and 12 years as a member of the Health Subcommittee of Energy and Commerce in the House of Representatives. So I come at it from that perspective. And Kelly, the old adage or saying that don't throw the baby out with the bathwater, that goes right along with my specialty of OBGYNs. I'm really, but having said that, put me down for Stark rocked in 1989 and Stark sucks in 2019. That's an overstatement, of course, on both ends. But yes, I just wonder if the thought of really totally eliminating Stark. I like your comments on that. And then also your comments in regard to the rules and regulations, the final rules and regulation, Paul, that go into effect. How is that going to ultimately affect your practices and your risk, Jeff, as a continuing practicing physician, a family practitioner, and also healthcare administrator of a medical practice group? If you get your wish, maybe as Debbie's expressed her concerns, what ultimately is going to happen to you guys and more importantly to your patients?
It's a great question, and I think we'll be able to be a little more creative in some of our compensation models for physicians. Right now, we have a couple of compensation models based on specialty and venue of care, but by and large, it's productivity-based, and our physicians are activated in this. They want to do something differently, and sometimes compensation is the carrot and the stick, so to speak, but I think we can be more creative in our compensation models to allow for more value-based compensation at the singular clinician level. So I think that we'll be somewhat liberated because we'll be able to take our clinicians off that RVU treadmill that some of them feel that they're on, especially in the primary care service line that we have. Our primary care service line in Wisconsin alone has over 800 clinicians in it, and so it's a significant band of clinical caregivers there, and to liberate them from that, we're not talking about burnout here today, but I think to do something meaningful in your day-to-day and know that your compensation is aligned with that, I think would speak volumes across our medical group.
I guess I might do just a flashback story, a personal story of trying to, receive medical care. I mean, one of the groups that was carved out of the Stark Laws originally was ambulatory surgical centers. I would argue that's because doctors already owned them, and we couldn't really pull that genie back into the hat. I had to have knee surgery about a decade ago, and I went to a physician here in the DC area, and he said, you need to go to my ambulatory surgical center. I said, first of all, where is it? And he told me, and I literally had a neighbor who died there. And so I said to him, I'm not going there. I've never had surgery, and I'm not going to do that on a road that I know is far away from any place where I can get care. And by the way, do you have a physician ownership of this ambulatory surgical center? And he said, well, yes. Why do you ask? And I said, well, it seems to me you're incentivized to have me go there as opposed to the hospital. I'm giving you legit reasons why I don't want to be there. He said, I won't do your surgery in a hospital. And so I had to leave that physician and go find another physician in order to get my care. I think I'm a really sophisticated user of healthcare. Most people aren't going to ask that. Of course, that ambulatory surgical center was also out of network, which he had never told me, and that's part of the huge problem we have with surprise billing in this country. So that's something we missed originally with the Stark Laws. The more specific we get, the more we miss, and the more we let go around the corners. And so I just urge caution in all of this. I think it's a really difficult area.
Okay, additional questions? Yes, we have one right here. And if you could please give your name and affiliation.
Thank you. Good morning, everyone. I'm Tim DeBay with PCMA. One of the words I didn't hear yet in the last 70-something minutes is drugs. The proposed AKS rule considers either including or specifically excluding PBMs, drug manufacturers, DME suppliers. What would the consequences on practice be if such a large fraction of Medicare spend is specifically not addressed in a final rule next year?
I'm happy to jump in and then turn it over to Debbie. From my perspective, the exclusion of drug manufacturers, DME suppliers, labs, et cetera, that's not the way we should go. I feel like to the extent that there is concern about certain types of behavior, that behavior should be addressed in the rules, and we should not exclude, certain types of entities wholesale. I would also like to point out that, the Stark Law generally is not going to apply in the context of manufacturers, so this is more of an anti-kickback statute issue. And from what I understand, and I don't know, maybe someone on this panel can confirm, probably you, the agencies have indicated, or Azar himself said in a speech, that the agency is planning to promulgate value-based safe harbors specific to the pharmaceutical industry next year.
I will direct my answer specifically to this proposed rule, and I'll say that those are the types of issues that we're seeking comments on, and I believe I brought it up about pharmaceutical manufacturers being excluded. And the reason for that is, as it's spelled out in the proposed rule, is because of potential concerns with fraud and abuse and historical issues with those types of in the industry. With that said, we would like feedback and we would like comments as to whether or not those particular aspects of the industry can be included while at the same time providing the correct safeguards. And so I think these are great ideas, and I'm glad that I'm here to listen to them, because those are the exact types of issues that we do want to address and make sure that it is correct if a final rule is finally published.
And I would say I read those exceptions as making clear what Kim said, which is that the IG worked closely with them on this. And there is such a long history of fraud, abuse, harm in those arenas that the direct carve-out, to me, was an acknowledgement that they're really trying to do a good job on this, that this isn't just wipe it all away. And so I took that as positive.
Okay, additional questions? Yes, right here.
It's really a comment.
Okay.
Michael Cook, I've been a healthcare lawyer for about 40 some odd years in government initially, and then back in the 70s, and then in private practice, large firms, and now a much smaller firm with two colleagues who used to be national healthcare fraud coordinators at Justice. I was sitting on a plane next to, back when the initial Stark Law and Labs was enacted, sitting next to a fellow who was a competitor flying out to a conference, and he looked at me and he said, "This could be a big deal, I think." It was that sentence. I have partners and colleagues who, aside from the anti-kickback laws, which have kept many of us employed, I have partners, thank God I haven't done it, who have been dealing with the Stark laws forever. But I remember giving an initial speech to some docs at the American Medical Directors Association when the first larger set of regs came out. They would have needed, watching them and reading it, they would have needed a lawyer for next to their side to go care for a patient. A number of the provisions that we and opinions that we give are $20,000 and $30,000 a pop, or going, yeah, maybe that works for a large hospital system or a large company. For the doc who's in 2 or 3 docs, you're going to do that? Not a prayer. When they did when Atlantic City Medical Center, which was written about by Gawande, did their first coordinated care episode where they took a cap for the gaming industry, they really took a chance because they were giving to the docs out there MIS help. That was a lot of money. It saved a lot of people, and it showed us the way to coordinated care. Whatever you do, you cannot stop. And I was, as I said, in the 70s, I remember a boss coming to me and saying, "We can't stop somebody from stealing from the Coke, 10 cents for the Coke machine and worrying about that. We can't stop. Someone, as you pointed out, will find a way around the regs." So you've got to find a balanced approach and then go after the bad actors as they do it.
Is it possible to do this as we go, find the bad actors and get to them as they do it? I mean, with the changes we're talking about making, is that going to be harder? Is it possible? How do we do that?
Well, I'd say to more broadly enforce the regulations, people need to understand the regulations. And if there isn't broad understanding, you're not going to have people saying, "Hey, you're doing it wrong. You could be doing it differently." And that's, I think, a takeaway for me is unless we get to broader understanding, true grassroots understanding of what we're trying to accomplish with these regulations, we're not going to get meaningful enforcement of it.
And that's where I started. I mean, Pete would go back and say, "Thou shalt not self-refer." It has become a roadmap. It's not an easy roadmap to follow, but it is a roadmap. And it's very complex, and there's no question that things could be simpler.
Mm-hmm. Okay. Oh, there's a question? Oh, all the way in the back, I see a hand.
Hi, my name is Jaleesa. I'm a research associate at the Cato Institute. I know years back in the 80s, there's the idea that healthcare was a natural monopoly, and that's why doctors work with other doctors and work with hospitals. Do you believe that the changing of the Stark laws will once again enforce that idea that there are these natural monopolies and that's the best way to provide for patients?
I think that's a bigger philosophical question and a matter of opinion than the Stark laws contemplate at all.
Yeah. Anybody else? Okay. Okay, so this is a good stopping place for us.
Thank you. Thank you, Marilyn. Thank you, panelists, for a very lively and informative discussion. As I said at the outset, this is the last health policy event, public event we're having this week, and for 2019 from the health policy team for 2019. But I want to take the opportunity with the audience here and with the webcast to highlight something coming in early 2020. And that is that on February the 5th, after almost 2.5 years of work, we had something here called the Future of Health. A little pretentious, but the Future of Health. And this was a group of 10 highly respected policy analysts who have been working to deal a lot of the issues that you've been talking, not just Stark, but a lot of issues here. It is being co-chaired by Senator Daschle and my last boss on the Hill, Senator Bill Frist, along with Andy Slavitt, former CMS acting director, I believe, and Gail Walensky and a number of other high-level healthcare policy analysts. And we'll be releasing that on February the 5th going forward. And you'll get, all of you, since we've got your emails, you'll get a notice of this. We can't hold it here because we're expecting a great deal of turnout. And that is appropriate time for me also to say, and just if you'll allow me to take this opportunity, because after 2.5 years, this young lady over here, Natalie Wiener, will be leaving us. She's been a project director, has helped Catherine, has helped Marilyn, has helped me throughout this process going forward. So wish her goodbye. She's going to more work in this area, so that's great. And then finally, as I said, this is the third and final event this week. And we do have a director of events over here, Jolene McNeil. It just happens to be her birthday today, so happy birthday, and thank you all for coming out.